Old gentleman, chronic alcoholic and chronic smoker, presented with complaints of pain abdomen in the right upper quadrant and the epigastric region. Patient on a per abdomen examination, the abdomen was distended and there was tenderness present in the right upper quadrant in the epigastric region. Ultrasound showed feature. Ultrasound was suggestive of left lobe and right lobe liver abscess. Right lobe liver abscess was 600 cc in the segment 5 and the segment 7, and there was a 400 cc abscess in the left lobe. Patient was managed by percutaneous pigtail insertion 3 days ago. The total output since then has been almost 600 ml in the right lobe, and in the left lobe there has been almost 100 ml output. Both were purulent output, which has been sent for pus culture and sensitivity. Since then, patient has also developed symptom. Patient has also developed altered sensorium, and has also is also not speaking insensibly. And patient has developed symptoms of alcohol withdrawal syndrome. Patient was started on IV antibiotics, including third generation cephalosporins with double dose metronidazole. Along with that, patient was also started on vitamin K and thiamine injections for 5 days.
Now, who is going to draw the segment 5 and 6?
Yes, sir. Segment 5 and segment 7 both, sir.
So, what are these segments? You can also come in front. What are these segments they are talking about?
Segment and 6.
Can you draw them? In our segment? You can use an iPad. Take a fresh page.
Based on the portal vein into right and the left lobe, and also along with the hepatic vein cell, hepatic artery. With
Cunard is a French system of division.
Cantle line going from the right side of the portal vein to the left of the gallbladder, cystic plate, and then
Left of the portal vein to the right of the gallbladder.
portal vein, sorry.
Gallbladder fossa. Okay.
Then one is the caudate lobe behind. Then 2, 3, 4A, 4B, 5, 6, 7,
And 8.
8.
It's simple. And one is independent liver. One is a liver in itself. It has its individual independent arterial supply, portal vein drainage. Now, so when you are using this term, segment 5, segment 6, you should know where it lies. What is the significance of Cantley's line, Terry? They mentioned about Cantley's line just now. So what is its significance?
So I just know that it surgically divides the liver into the left and the right lobe.
Okay, that's one. Any other? Sabyasachi,
Middle hepatic vein.
the middle hepatic vein lies in this line. And that is the significance. Yes, it divides actually into true right and the left lobe. Now, this patient has got alcohol withdrawal. We discussed it earlier also. Now, what all? We have discussed liver abscess many times, so maybe they'll rattle it out for you. They are amoebic and pyogenic. So is it amoebic or pyogenic according to you, Ayush?
So it is multiple liver abscesses, so it is probably a pyogenic liver abscess, and you can also see the drainage in the liver abscess is purulent drainage. In amoebic liver abscess, we would get a typical anchovy sauce drainage. So here it is only purulent, so it is probably a multiple liver abscesses, pyogenic abscess.
More?
So same thing. So the patient is also like his immune state is also compromised, and multiple abscesses which are draining like non-anchovy sauce drainage. So mostly.
Patient had it come with in a state of sepsis, so that is more common with the pyogenic liver abscess. Now, for the benefit of all the students, the liver abscess is more common on amoebic liver abscess is more common on the right side. Why is it so? Vikotso?
the bare area of the liver is on the right side, so
Okay, one is the bare area, the other is right lobe is little bigger. And the third reason is very theoretical, is the portal drainage. It is like straight on and this is at an angle. So there is a turbulence of flow. And the right division of portal vein is more likely to carry the amoeba. And it's more common from the right side of the colon also, that is ascending colon and transverse colon. That's where the source is usually. So amoebic is more common there, and yes, it is common in the bare area of liver. Where is that according to that segment distribution? Segment 8. So it's a portion where there is no peritoneum. Peritoneum is reflecting. So that bare area has no protection of peritoneum. So that's why the incidence is very high. What are the gynecological causes for liver abscess, Dr. Sumita? You would see that in gynae, that's why I'm asking.
Immunocompromised status.
So what would the source be?
So maybe ascending infection from the vagina and cervix.
Yeah, it is the cause, yes. And also PID.
PID.
Sometimes, the patient has presented with all features of right iliac fossa pain, tenderness, guarding, Murphy's triad being present. It's actually classical appendicitis and patient has got jaundice. What should he suspect? Appendicitis with portal pyemia. And portal pyemia could be just one presentation. It happens in enteric fever also. And portal pyemia would present as jaundice. Similarly, any pelvic inflammatory disease in an immunosuppressed individual is likely to cause pelvic peritonitis. Primary pelvic peritonitis, which is not bacterial. It is bacterial, but we can't make out the cause, so that's why we call it primary. What is the usual scenario in primary peritonitis?
Yes, patient presented with a pain abdomen and
All features of peritonitis, and you don't find a cause. But some people believe that it's a secondary infection in an ascitic fluid, but it's actually pneumococcal. Now we know that. So we need to be careful about that. And it's common in gynae. The trouble is if you just refer cases, so then you would not know that the treatment lies in what you are doing. So if there is even following Michel merge, which has got infected now, which is a mid-cycle pain, very similar to appendicitis, because both have the same dermatome, so it starts around the umbilicus, localizes to the right iliac fossa. You may confuse that it is due to something related to liver, and patient keeps getting sent everywhere, but you understand it's a ascending infection. So what have you done?
So we have kept him on IV antibiotics. Sir, we are also maintaining his hydration by IV fluid. Although we are encouraging his oral intake, he is taking that adequately. We started IV thiamine as we were expecting him to go into withdrawal, and we have also sent a psychiatry call.
Anything else, Terry?
Sir, along with that, we've started vitamin K also, sir, to address the decrease of the clotting factors, sir.
Is the coagulation deranged?
It was deranged, sir, earlier. It was like when he arrived, it was 1.8, with INR was 1.8. So, but now it is all right, sir.
Treatment. 3 questions which are related to this patient. 1. If you are an alcoholic with liver abscess, how do you in your practice take a decision about percutaneous aspiration? As a registrar, when do you decide I should aspirate, put in a cannula, or just managed by drugs?
So firstly, clinical findings, the patient is symptomatic, sir.
Symptomatic for what?
So local peritonism, sir.
so patient is symptomatic and has a high grade fever despite the giving antibiotics and antibiotics and abscess in the left lobe of the liver. So the likely chances of rupture into pericardial cavity, and even in the right lobe of liver, there is a large liver abscess which is.
That's what I was trying to know. Himanshu, what is large for you?
So large liver abscess, it can be more than 200 cc, or if there are multiple liver abscess also, so the one can also try just for the pictate drainage, or we can put the tube also.
Anything to add, Junaid?
So when the abscess might be, sir, the volume is small, but the overlying parenchyma is so thin, the chance impending rupture is there.
You're saying impending rupture is important.
We need to drain it, sir, completely. Subcapsular.
What ultrasound features would scare you, would bother you? Impending rupture, subcapsular rupture. Third,
A small rent in the capsule, sir. There's a rent in the capsule which is likely to rupture.
the rent in the capsules or rupture. What else?
Subdiaphragmatic
Location of the
connection.
ultrasound. Location based on the ultrasound.
No, that is okay, that he has said left side. He has answered all. I am asking a different question. what ultrasound features would rush your system into running into anxiety? I hope you're following. Liver abscess comes as a full-fledged question in your exam, and I've covered it all. If you are not sleeping, you got the answer. You can read it in the book. There's not even a word extra, maybe word less. So better write it down, and that's a treatment. Yes. Ultrasound features. So he'll start again. Which features would warn you, would scare you? No?
CBD.
So IVC infection can be spread from liver to IVC, and it's called septic cardiomyocarditis.
You mean associated cardiac features?
Yes, sir.
Okay. What are the features of anaerobic infection in a liver abscess on ultrasound?
Gas.
So if there is gas in it, what all comes to your mind?
Maybe perforation. If the gas in
The
the
gas in the abscess. Yes.
abscess,
I'm not talking about pneumoperitoneum.
There will be a rent in the diaphragm, sir, associated with
With the gas forming organism, where is the problem?
So bacteroids.
Bacteroid. So it is superadded infection might have been there because of the liver abscess, it might have been amoebic, which has been infected secondarily by some bacterial. And such, it also indicates that the immune status of the patient is very poor because it usually happens in.
Like you have the emphysematous cholecystitis, you can also have emphysematous abscess, right?
yes, sir.
Now, what else you would like to see? Where can the gas come from? One is the organism.
Yes, sir.
Second, he said maybe communicating to the lung, not to diaphragm. That makes no difference. Or
In one sequence, sir, there is chilagity symptoms.
the chilidity is a normal person,
Yes, sir.
asymptomatic,
Yes.
and there is no communication. Yes, Junaid. What is pneumobilia?
Hair and biliary tree.
What are the causes of pneumobilia?
Most common cause is iatrogenic, sir, post CRCP. And then the
Post CRCP and
Bilioventric fistula.
bilioventric fistula. Gallstone. What is Gallstone ileus?
when in presence of a gallstone, sir, we don't have peristalsis present. If it travels down, sir.
Characterized by a triad of regular triad where the stone in the GB has more of fistula with the duodenum, where we find the stone in the distal ileum with pneumobilia and appearance of obstruction. These
Good.
three
Come
form.
here. Come here, Rishi. You have graduated to the SR group now. Come. They couldn't answer that. You answered it. Repeat what you said for the benefit of everyone.
So Gallstone ileus is defined.
Is Gallstone ileus?
Explain
क्या
the
समझने लगा?
question.
Dynamic.
Is it a dynamic obstruction or adynamic?
Dynamic.
So first of all, this ileus term is misnomer. It is a gallstone, which is also called a tumbling stone, that has gone to the terminal ileum to produce obstruction. So to be able to do that, it has to be large. And to be able to be coming out, if it is large, you need an end fistula. It can't come through the normal route. So there is invariably, are you following what I am saying? Usual story, right? And there is a stone here, which is very big. It can't come out this way, so it has to be a cholecystoenteric fistula. So it will trickle down. It will go to the terminal ileum and produce the obstruction. So that's why we call it tumbling stone, a tumbling obstruction. Now, this ileus term is a misnomer, because this is a dynamic obstruction. If there is dynamic obstruction, you will have all the features of intestinal obstruction. In addition, would this stone be, you've done an X-ray abdomen. Would you make a diagnosis of gallstone ileus simply based on X-ray abdomen? Yes or no?
Yes, sir.
Yes, sir.
Air in the gallbladder.
She says air in the gallbladder would take care of it. You? You also said yes, that's what I'm asking.
Yes, sir. Air in the gallbladder and as well as air could be present in the CBD and there is
हो गया pneumobilia, huh?
Yes, sir.
Let's kill it, otherwise each one will use one answer and take my whole day. Pneumobilia means all of them, no? Over?
Yes, sir.
अब आगे. Next move.
The stone in the bowel.
This stone is radio opaque. Gallstones are not radio opaque. So how is it radio opaque?
So while traversing in the gut, it picks up the calcium.
Very good. Calcium deposits on it. And it absorbs calcium from the intestine. So common gallstone is radiolucent. But this is radio opaque. So X-ray abdomen can show you both. And what is the gold standard investigations for intestinal obstruction?
Contrast and CT scan.
So you would do that here also. Gold standard is not X-ray abdomen erect and supine. But X-ray abdomen erect and supine can also make a diagnosis. X-ray abdomen erect will show you air fluid levels, which will indicate that there is intestinal obstruction. And if you take a supine film, you'll know where the obstruction is. So erect to find out if there is obstruction, supine to know where is the obstruction. This is the concept. But CACT will confirm it. Now comes the question of gallstone ileus started with the gas that we were talking, but I'll finish this. So it has two parts to it. There was a stone in the gallbladder, so naturally there was some